Good afternoon. At the onset, let me thank Gautam and the organizing committee for inviting me to your beautiful city. It's always a pleasure to be here. All of you, or whenever we are going to conferences, over the last few years, we are hearing this talk of freeze-all, and clinics are more and more saying that they want to do and they want to follow this for every patient that comes through. So what I want to do today is we will look at this strategy from a point of view of what kind of evidence we have about this. So this is the outline of my talk. We'll see how it started, what are the indications, what are the evidence that we have for effectiveness, what have been the disadvantages and advantages of this particular strategy. So it all started way back in 2011 when Paul Devroy proposed a concept of OHSS-free clinic. And the reason for that was they observed an incidence of around 2% of severe OHSS. And at that time, almost the clinics in the West were reporting 3 deaths per 100,000 IVF procedures. And that was alarming. So they proposed a strategy to use an antagonist cycle with the agonist trigger and freezing all the embryos in a hyperresponders. As the time went by and vitrification became a norm, and we had fantastic results with vitrification, more and more clinics started thinking about it, and newer indications were added. So now we have come to a stage where clinics say freeze all for every patient. And they have different reasons. So what are the absolute indications for this? As we know, preventing OHSS was the main reason, followed by which it was observed that progesterone elevation at the time of HCG was another reason. Obviously, if you want to do PGD or PGTA, then you need to freeze all the embryos. When we come across undiscovered pathologies like thin endometrium, polyps, myomas, hydrosalpinx, fluid in the endometrium, and people feel that we shouldn't transfer in the cycle, then freeze-all becomes a norm. Very interesting thing will be evidence that we have today, which says that day 6 blastocysts seems to have a very similar potential, and transferring them into endometrium, which is advanced than them, would waste them, and freezing them and transferring them in a subsequent cycle would restore their potential of becoming children. So that was another indication. Fertility preservation for cancer patients. When ERA came through, personalized endometrial ETs, for that you need to freeze everything. Patients with high thromboembolic risk were also subjected to this. And then started other indications like it was easy to schedule, random start, double stimulations. Another proposed was embryo pooling for poor responders. And this comes from a fact that if you want to do PGTA for poor responders, you need to have certain number of embryos to make it commercially viable for the patient. So you need to then store them and then kind of do this thing. And then people started talking about that freeze-all gives us higher pregnancy rate. So let's look into all of these things. Why will this improved pregnancy rate was proposed? It was said that you'd want to transfer in the more physiological environment. So what does it mean? We think that supraphysiological levels of estrogen are detrimental to implantation. But the problem is, nobody has defined this level beyond which it becomes supraphysiological. So it's just a theoretical terminology. And we really don't know whether the steroid hormones behave this way. The basic question is, after a certain level, I think all the receptors are occupied. I do not understand how supraphysiological levels are going to bring about effect at the cellular level. Late follicular phase progesterone rise has a negative impact on implantation, and we know that cycles with recombinant FSS tend to have a higher progesterone and higher estradiol level, and maybe that's the reason why some of the antagonist cycles have an adverse outcome. When I remember, I look back the time when antagonists were introduced in the clinical practice, the pharma companies promoted as a flexible protocol, and that was a disaster because people wouldn't get people pregnant in the fresh cycle, and the same embryos will do fantastically in a thaw cycle. And the reason was we were missing minute elevation of progesterone since we started the antagonist few days later than what should have been. And apparently all this got corrected when fixed protocols were introduced. So it seems to be something the way we manage this patient in the stimulation phase. Another issue is when we prepare endometrium for these transfers, what is the most physiological endometrial preparation? And we don't know that answer for that. So people talked about improved success, and what I'm going to now show you is to give you a thought process of how to look at the literature that keeps coming to you. And I'm going to mention a few names over and over again, and you will see how these authors have changed their opinions over the time. So way back, this paper came from Rook, and he seems to be at the forefront of looking at freeze-all since, I think, 2015. So the first paper they came out quoting 3 papers, and they said that it improves the outcome. And the funny part is the first paper was withdrawn, and it was criticized for faults in their methodology. And the next 2 papers come from the same group, and very few numbers. Later on, he also again came up with another paper which says that it improves the success rate. But the problem was this was not an RCT. And funny enough, when you read the whole paper, then he says that the progesterone level of day of HCG was a criteria. So it was not really freeze-all in the sense that you would perceive it. It was indicated for progesterone elevation. So obviously, you're going to have a better outcome in freeze-all. So this was basically, as you know, was all proposed for patients who are hyper-responders. And what happens when you look at the normal responders? So it's a very good paper, quite large RCT with almost 400 patients in each arm. Antagonist cycle, when I now talk about papers, mark these 3 points: cycle, what day embryos were frozen, and how they were transferred. So they documented that similar pregnancy outcome in the fresh and freeze-all cycles. Now, these 3 papers I have chosen for a very important reason. 2 of them are from New England Journal, and 1 is from Lancet, because it seems that the first 2 are actually from the same group of researchers. It's a consortium of clinics or university setups in China, and they have large numbers. Very interestingly, the first paper talks about PCOS patients, a randomization done. Again, fixed antagonist, day 3 embryos frozen, and first embryo transfer was compared. Showed higher live birth rate and lower losses. The rest I'll come later. But again, higher frequency of preeclampsia. The same group, when they conducted this study for normal ovulatory patient, again, fixed protocol, day 3 embryos, no difference in the outcome. And again, no difference in the obstetric and neonatal outcome. When the same researchers looked at, again, normal ovulatory patients, but now they changed to blastocyst freezing, and then they have both natural cycle and artificial. As you can understand, the first paper would always be the endometrium prepared by artificial oral estrogen and progesterone, since they were PCOS people. And the second paper is for natural cycle, and the third one has a mixture of natural and artificial cycle. And now they document higher pregnancy rate, but no difference in the neonatal complications. So we need to understand that having strategies which are different about the day of embryo freezing and the strategies how you prepare the endometrium may have an impact on what you see in the outcome of freeze-all cycles. Now let's look at some recent trials. In January 2021, this large single-center randomized trial came from Netherlands, and as you know, the IVF treatments are free for all their patients. Again, unselected patient, 102 patients in each arm. It's a relatively small number. Very interestingly, the difference now here is they use long protocol and did blastocyst transfer, mainly SCTs, and somehow they feel that cumulative ongoing pregnancy rate is much better in the conventional strategy than freeze-all. So this is something we need to understand and think about, whether the stimulation protocol has something to do with what happens when you're trying to look at freeze-all. And as I said in the beginning, antagonist protocols initially gave a lot of trouble, and maybe these troubles are still lingering. Still, we do not understand the best way to manage antagonist cycle. And maybe when you have a long protocol, the picture is very, very different. So this is something to think about when you go back. Now, when we have all this confusion, we need to go to meta-analysis. Dr. Kamath is here. He's the master of meta-analysis. And again, Rook comes with a meta-analysis in 2019, showing higher live birth rates only in hyper-responders. No difference in the normal responders. Again, increased risk of preeclampsia. Another analysis with 5 RCTs showed no advantage when the mean number of oocytes were less than 15. So again, there seems to be some relevance to it when your numbers of the oocytes are higher. If you look closely at the analysis that Rock puts forward, the outcome evidence of quality is low and very low about the cumulative pregnant birth rates, whereas there is a relatively better evidence for the complication, that is preeclampsia, which has a moderate degree of quality of the evidence. So eventually, this year, Cochrane updated the last review, and now we have more than 4,000 women in the studies of 15 studies. No difference in the cumulative live birth rate, moderate evidence. No difference in the ongoing pregnancy rate, moderate quality of evidence. And low quality evidence showing that hypertensive disorders, large for gestational age babies with freeze-all. Another paper from Acharya et al. Infertility Sterility in 2018 showed that the hyper responders are one who do better with FET. Normal responders and poor responders do better after fresh ET. So all of these studies are telling us that we should not be indiscriminately doing freeze-all for patients who respond normally or who respond poorly. And old papers in 2016, they are not even papers, they were papers read in a conference in 2015 and 16, which showed better outcome. But the problem is, again, if you read the methodology, you have progesterone as criteria. Funnily, this paper from Turkey says patient's choice was a criteria for going into the arms of the study. So we do not recommend doing freeze-all for poor responders. So overall, there's a lack of good quality evidence, especially for live birth rates. Most studies are underpowered, and patient selection, stimulation protocol, triggering, the patient protocol used for ET are all going to matter when it comes to outcome. We have some hope because there are quite a number of RCTs, which I have mentioned the numbers. They have been registered at this moment, and some of them must be already finished because I took these numbers about a year and a half back. So maybe that data will make us a little wiser. So let's look at the perinatal outcome. As gynecologists, we should not be just concerned about the pregnancy rate. And there has been some concerns. A single center, single blastocyst, fresh and vitrified thaw cycle. I'm not talking right now about this study of a freeze-all, but what freezing can do when we should be careful is this shows that the vitrification group has a higher chance of preeclampsia and large gestational age without diabetes, and small for gestational age and preterms were comparable. This study is important because it comes from one center, so all the methodologies are same. So it seems that freezing blastocysts and thawing them may increase the risk of these problems. When we look at large data coming from Scandinavia, you have huge amount of IVF pregnancies reported, which show that if you look at this data, increased risk of PIH after all ART procedures and more pronounced from a frozen thaw cycle. Very interestingly is they analyze the data for when women gets pregnant twice with fresh cycle and then with the frozen cycle, the sibling risk was higher after frozen thaw cycle. So we just cannot say so confidently that everything is perfectly well when we do freezing and thawing. So we need to look at this. The Swedish registry shows higher rate of large for gestational age, higher perinatal morbidity, and higher rate of PIH for frozen thaw cycles. Again, it can be disputed saying that the best embryos are transferred fresh, the not so best are frozen. It will have some impact on these numbers, but we cannot ignore this warning that these numbers tell us. Recently, I came across this paper. Again, not absolutely applicable here, but again, it warns you. This is a data coming from comparison of egg donation cycles fresh versus frozen, which shows that fresh ET was associated with better outcome. They have defined what is our good obstetric outcomes in terms of the weight of the children, the prematurity, etc., etc. Again, it can be criticized saying that the best embryos are transferred fresh and not so best are transferred afterwards. But still, we need to keep this in mind. Also, we need not forget that there are risks associated with freezing. Cryo damage, toxicity, potential equipment failure in liquid nitrogen supply. All of you will remember during the last lockdown how desperate we were to top up our tanks because supplies were not coming in so very easily. Breach of packaging, contamination in storage, though not documented well, is a possibility. And again, loss due to human errors and disaster. We had recently a huge lawsuit in the US where thousands of embryos were lost because of equipment failure. So all of this also need to be taken into account. And again, never forget what is patient's point of view. Psychologically, there's a burden of postponement. Couple wants minimum time to pregnancy, and the studies show that the delayed is somewhere around 1.5 to 2 months to get pregnancy if you do freeze-all. Again, patients have to pay for that, and my estimate is as high as 30% extra charges are involved in freezing and then thawing in a subsequent cycle, so they have to have a cost burden also. And of course, they have a perception, even today, patients will have a perception that frozen embryos are inferior to fresh. It doesn't change anything, but again, that puts them into the psychological pressure that they're doing something which is not perfect. So, there are definite clinical advantages. Reduced OHSS, maybe flexibility of scheduling OPU, less stringent cycle monitoring, more oocytes, but all of that gives you a false sense of security, and overstimulation becomes dangerous. So, you should not take this so lightly. A paper in Human Reproduction did a beautiful SWOT analysis. You should look at this paper and see this diagram. It's absolutely fantastic the way they looked at the process of freeze-all. So, freeze-all has a role in specific circumstances. Drastically changing the current clinical practice cannot be done without high quality of evidence, which is sorely lacking right now. High quality research with large RCTs are the need of the hour. And when we talk today of era of tailor-made therapies, individualized treatment, do you think freeze-all, one-size-fits therapy is appropriate? I think it's highly inappropriate at this moment. So I urge you to look and read data, read papers more carefully, and then analyze yourself whether you should be advising this strategy for every patient who walks through your clinic. Thank you.